Okay, so the definition of self-harm that we use, and that the majority of research in the UK uses, is one of intentional self-poisoning or self-injury, irrespective of type of motivation. Now, by using this definition, we're including all forms of self-harm, from medically minor types of harm, such as cutting and scratching, all the way up to including more medically serious types of self-harm, which might be considered as suicide attempts. But by including all types of self-harm, we're not limiting ourselves to thinking about motives or intentions, that we have to have reported intentions and assumptions about whether people wanted to die or not. We're avoiding that completely by including everybody as one group. Okay, I also wanted to give you some examples of service users, some quotes from them about why they self-harm. There are a lot of reasons why somebody might self-harm, and these are just a few examples, and I'll read them out to you. Okay, so this first one says, "Pain works, pain heals. If I'd never cut myself, I probably wouldn't still be around today. Don't get me wrong, not in a heartbeat do I think that self-harm is a good or positive thing, or anything besides a heartbreaking, desperate act that saddens me every time I hear about it. But there is a reason why people do it." The next one says, "I don't deal with daily stress well. So when extra events occur, however big or small, my tension levels rise, resulting in my needing a release. Self-harm has proven to be the most successful thing in dealing with this." So you can see that self-harm means a lot of different things to different people. It's already been mentioned by some of the speakers earlier today, but sometimes some people who self-harm do want to die. Some people who self-harm are trying to communicate some kind of distress or handle some kind of distress. And other people, like this example, are looking for some kind of release of an overwhelming emotion or situation. Okay, so I'll move on to talking about what we actually do at the Manchester Self-Harm Project. But before I get to that, I thought I'd show you the pictures of our team, who aren't here with me, unfortunately. So we're led by Professor Nav Kapoor. He's principal investigator. I'm the project manager. We have Harriet Bickley, who is a research assistant and database manager, and Jackie Ward and Ian Donaldson, who are both administrators, but their main job is data collection. Our project's been running continuously since 1997. This means that next year will be our 20th anniversary, so hopefully we'll be doing something for that in the autumn, some kind of event. What you can see here are some of our reports, covers of our reports, and we release a report just about every 2 years, as well as with various publications, and they're available on our website, which I'll put the details of up at the end. Okay, so our core purpose, our main remit, is to collect detailed data on people who attend emergency departments in the city of Manchester after self-harm. And you can see there's a map there of Manchester, and I've highlighted the 3 hospitals where we collect data. Those are the 3 general hospitals that cover the city of Manchester. We're also part of the multi-centre study of self-harm in England, along with Oxford and Derby, who run similar self-harm monitoring systems to ourselves. Okay, so our methodology is actually quite labour-intensive. And what happens is our data collectors, they go out and they look at every single presentation to those 3 emergency departments to see whether it's an episode of self-harm or not. That might seem quite straightforward, but actually from experience, we find that quite often self-harm is coded as other things, because self-harm is a behaviour and not a diagnosis. So we find that things could be coded as nausea or stomach problems for overdose, or we've had occasions where self-harm's been coded as head injury, which I can only imagine somebody was thinking mental health issues, head injury. So our data collectors are very highly skilled and have a lot of expertise in being able to identify these cases. Once we know which cases are self-harm, we then collect quite detailed data from a combination of medical records, emergency department assessments carried out by emergency department clinicians, and specialist psychiatric assessments that we get from the Manchester Mental Health Trust, which also covers the whole area. The information we collect includes detailed demographics, psychiatric history, details of the Self-Harm Act, any details of any previous self-harm, clinical impression at the time of the presentation. So did the person look depressed? Are they having problems sleeping? Are they having problems with their appetite? And we also collect information on where they were referred onto from the emergency department, whether they were referred to a mental health service, whether they were admitted to a medical bed or another care service of some sort. Okay, so you might be asking why we study hospital presentations for self-harm when self-harm is obviously a problem in the community as well. Which of course it is, and that's an important issue, and there are people working on that as well. But the reason we look at hospital presentations is that when somebody presents to hospital following self-harm, it creates a point of contact between the person and their local care services. And it provides an opportunity for intervention at that point to help people address any underlying issues, to help reduce individual distress, and to hopefully prevent any future self-harm behaviour. Okay, so that was a very brief overview, and I'll just go through a few key things from the results of our work to give you an idea of what self-harm is like in England. Okay. So first of all, we estimate that around 220,000 people a year attend hospital for self-harm. It may well be higher. Because a lot of these episodes are repeat self-harm, these are made by about 150,000 people. We also know that people who attend hospital with self-harm are much more likely to die by suicide. As already has been mentioned a couple of times this morning, around 50% of people who die by suicide have a history of self-harm. So in Manchester in particular, just based on Manchester data, we find that people are 20 times more likely to die by suicide than people in the general population if they've attended hospital for self-harm. And some more recent work, which is for national estimates, shows that the risk is about 49 times higher than the risk in the general population. So I'm just going to talk a bit more about that mortality issue. And these two graphs, these are mortality, life expectancy in males and over time. And the height of the bar is our life expectancy of the general population. The red part is the life expectancy of somebody who's attended hospital for self-harm. And the lighter pink bit in between is the years of life lost. So if we look at the one that's labelled external causes on the right, this is external causes is things like suicide and accidents, and you can see that there is quite a huge dip in life expectancy for those people who have attended hospital for self-harm. But even, you might expect that, given the link between self-harm and suicide, but if you even exclude those people and you just look at death by natural causes, which is the chart on the left, you can see that life expectancy is still lower in people who attend hospital for self-harm. And on average, people who self-harm have 30 to 40 years lower life expectancy than an age-matched sample of the population. Okay, these are just the same graphs, but for females, and you can see that similarly, there's a lot of years of life lost for the external causes, for the suicide and the accidents. And while the years of life lost aren't as many as in the men, there's still a lower life expectancy for people who attend hospital for self-harm. Okay, we also know that more women than men attend hospital for self-harm, but the difference actually isn't as big as you might expect. The ratio is 1.2 to 1, which means that for every 12 women attending hospital for self-harm, 10 men are attending hospital for self-harm as well. So it's actually a much more equal than you might think. Okay, and the highest rate of self-harm is in young women, aged 15 to 19, but there are some interesting changes in rates that have gone on recently and over the last few years that I'm going to show you now. Okay, so this is rates of self-harm per 100,000 of the population over time from 2003 to 2013. The bottom line is males and the top line is females. And it's quite difficult to see from this particular chart, but there's generally a decrease in self-harm from the early 2000s up to 2008. And at that point, the rates in women sort of level off a bit and slightly go up. But in men, they actually increase quite dramatically. And you can see that by 2012, the difference has closed. The gap between the males and females has really closed. And it's just starting to open up again. So it'd be interesting to see where that goes next when we get the next couple of years of data in. Okay, so this is rates of self-harm again per 100,000 of the population, and this time it's in age groups in women. And these look quite straightforward. We've got the youngest women at the top all the way along, the oldest women at the bottom all the way along, and they don't have much change over time. And the two middle-age groups, 25 to 34 and 35 to 54, are quite close together in the middle. But if we look at men, it's quite different. You can see that there's quite a lot of change over time. The rates go up and down quite a lot. And particularly from 2008, the 35 to 54-year-olds go from being the third highest rate to being the highest around 2011, 2012. And they peak at 2012, and they're quite a lot higher than any of the other age groups. Now, we speculate that this has something to do with the economic recession that hit in 2008 and the ongoing impact of that. But it's an interesting result that this particular age group have increased so much. And again, it'd be interesting to see where these rates go now and in the future. Okay, we also wanted to make a comment about ethnicity of people who present to hospital. Unfortunately, we only have very broad categories for ethnicity, but you can see that the vast majority of people who present to hospital for self-harm are white. And this is interesting because it's 85% white people on this graph, and this is Manchester data. And Manchester's demographics are only 66% white, which means that there's a much lower proportion of people from other ethnic groups attending hospital in this way. There's a couple of reasons this could be. It could be that people from other ethnic groups just don't self-harm as much, but the more likely explanation is that people from ethnic minority groups have different ways of seeking help and don't actually come to hospital for self-harm, but use other coping strategies or don't seek help at all. That's something that needs to be looked into. Okay, so just one more point in this section is the role of alcohol. Alcohol is one of the risk factors for completed suicide as well. And alcohol is involved in nearly 60% of all episodes of self-harm. And about a third or over a third of people who present to hospital for self-harm report having some kind of issue with alcohol misuse or alcohol dependence. Okay, so I'm going to move on to the last section, which is about hospital management of self-harm. And as previously mentioned, self-harm is one of the strongest predictors of future completed suicide. As such, it's a reduction of self-harm via good quality care is one of the key goals of the suicide prevention strategy for England. Okay, and to that end, a number of guidelines have been published about how to manage self-harm, including in the hospital setting. And these are designed to help services support people to reduce their self-harm, eventually to end self-harm as well. Okay, in 2013, NICE published a quality standard for self-harm. NICE is the National Institute of Health and Care Excellence, which is an independent public body that set up to help improve outcomes for people using health and social care services. In 2013, they published this quality standard for self-harm, which had 8 key recommendations, which when implemented should result in best practice, in better care. So I'll just quickly go through these 8 recommendations. They say that people who self-harm should be treated with compassion, respect and dignity, an initial assessment of physical health, mental state, social circumstances, and risk of suicide or further self-harm should be made. A comprehensive psychosocial assessment should be carried out. People should be monitored at whatever level they need to keep them safe, and they should be cared for in a safe physical environment that discourages or limits opportunities for further self-harm or distress. They should have a collaborative risk management plans in place if they're under more than one service, and they should have access to psychological interventions, and if they're moving between services at all, there should be a transition plan in place. Now, what I want to look at is the first 3. Okay, so quality statement number 1 is that people who have self-harmed should be cared for with compassion and the same respect and dignity as any other service user. Unfortunately, we know that this isn't always the case. There's a lot of stigma around self-harm, and sometimes they come up against very negative attitudes by people in the emergency department. And I have a couple of service user quotes for you, or rather one service user quote. This says, "The last time I had a blood transfusion, the consultant said that I was wasting blood meant for other patients after they'd had operations or accident victims. He asked whether I was proud of what I'd done." And I also have a quote which is from a member of clinical staff, which just describes the kind of attitudes that these people are coming up against when they actually attend hospital. So this person said, "You think they are troublesome, time-consuming, and are in the ward unnecessarily, which is for physically sick people who need the care." So we know that negative staff attitudes do actually impact on the people who self-harm and quite often discourage people from making further attempts to seek help for their self-harm. So quality statement number 2, people who have self-harmed need to have a rapid initial assessment of physical health, mental state, safeguarding concerns, social circumstances, and risks of repetition or suicide. And what I'd like to focus on for this part is the last bit about assessing risk of suicide and further self-harm. Because the guidelines state that you shouldn't use risk test assessment tools and scales to assess risk or try and predict risk of future suicide or self-harm. And that you shouldn't use risk assessment tools and scales to determine who should and should not be offered treatment or who should be discharged without referral. You can, however, use risk assessment tools as part of a larger assessment, a larger conversation, because they could be useful to help prompt the conversation or structure the conversation in some way. But they should, it's very clear, they should not be used on their own. And here we have a risk assessment tool. This is the sad person scale, which has just 10 items with which to try and predict whether someone's going to hurt themselves or not. A colleague of mine on a MASH-associated project, Leah Quinlivan, recently carried out a review of risk assessment tools, and she found that they were overwhelmingly poor predictors of future suicidal behaviour, and she in fact found that their prediction could be as low as 5%. So in 95% of cases, some of these tools are just wrong. Okay, Leah also carried out another study where she looked at a sample of hospitals in England to see if these tools were still being used, even though the guidelines say that they shouldn't be used. And she found that they were, in fact, still routinely in use to assess risk in people who tend to self-harm. So quality statement number 3 is that people who have self-harmed should receive a comprehensive psychosocial assessment. And psychosocial assessments are important because in some of our previous work, we found that hospital presentations for self-harm, repeat presentations for self-harm were reduced by up to 40% by having a psychosocial assessment. So risk of repetition was reduced by 40%. We also find that the very act of having the psychosocial assessment is beneficial for patients. They actually get some benefit just from having those psychosocial assessments, and they're normally carried out either by a psychiatrist or a psychiatric nurse who are part of the liaison team in the hospital. Another former member of staff on the MASH team, Cheryl Hunter, she carried out an interview study looking at the issues around psychosocial assessments and people's experience of them. And I've got a few quotes from her study for you. These are all service users, people who attended for self-harm. The main thing was that the psychiatrist did look as if he actually cared, and he really wanted to help me. At least I can speak to someone instead of just everything building up inside me. And when you're living on your own, you can't really talk to anyone. So you can see how important it is that people have this connection when they go into the hospital for self-harm. We also find that positive patient-staff interactions encourage people to seek help in the future. So this quote says, "I think I've got more confidence to get in touch with somebody now. Before trying to do something like that, I probably didn't have the confidence on that day to say, right, I'll walk into the hospital, I'll speak to somebody." Okay, so we know that psychosocial assessments are good. They help reduce repetition of self-harm. They have benefits for the patient more broadly as well. So the question is, are these psychosocial assessments actually being used in practice? So what this chart shows is some work that was carried out by Jane Cooper a few years ago, looking at the management of self-harm in emergency departments. And the bars we're really interested in are the first two bars, the mental health assessment, and that's the psychosocial assessment. This study was carried out in the early 2000s and then again in around 2010, so there's a 10-year comparison. And in that 10 years, these guidelines would have been published and should have been implemented. And you can see that actually over those 10 years, there's very little change in how people are managed, other than a slight increase in the number of people admitted to medical beds. And the important one, the two bars at the front, there's very little increase in the number of people receiving psychosocial assessments. And actually overall, despite these guidelines being in, saying everybody should have assessments, we found that only about 50%, on average, about 50% of people were receiving a full psychosocial assessment, even though the guidelines say it should be 100%. Okay, so that's the end of the presentation. I just got a few take-home messages for you. I just boiled down to a few points for you. If there's one thing that I would like you to take home with you, it's that self-harm is actually very common and that it can affect anyone, male or female, at any age and in any kind of situation of life. Rates of self-harm have increased since 2008, and particularly in men and men of sort of middle ages. Anyone presenting to hospital for self-harm should be given a full psychosocial assessment, and that people who self-harm should be treated with dignity and respect. And these are my contact details. If you want any more information or you want to look at any of our publications, you can find them at our website, or you can email us or follow us on Twitter. Thank you very much.